Thank you, Dr. Pragya, for the lovely introduction. I'm really honored. So today's my lecture is about, my topic is outcomes of ACL reconstruction surgery. So I did my PhD on this topic in the University of Otago in New Zealand, lovely university present in the Southern Hemisphere. So why I choose this topic is I'm gonna take you through this journey. So we have studied about the role of ACL anterior cruciate ligament in the knee joint, right? So we know, just for the students, we know that it prevents the anterior displacement of tibia during the movements, right? And because of its location here in the middle, it prevents the knee hyperextension. And it is a major stabilizer of the knee joint. So muscles move, muscles are the mobilizer, and this ligament is a stabilizer. So it is not just providing the stability in the sagittal plane, it also provides the stability in the transverse plane as well. So medial and lateral rotation of the tibia is also stabilized by this ligament. So from these roles, we can understand what will be the consequences if this ligament is ruptured and not repaired. So naturally, all these movements are going to be altered, right? So how does this injury happen? So if we look at the incidence rates, most of the injuries are non-contact type. So knee goes into weird position. For example, you can see this one here. So if you look at this right knee, so this one, the knee goes into valgus, the tibia is in a rotation, hip is in a rotation. So it's a non-contact type of injury. So mostly, but sometimes it can happen through the contact injuries during sports as well. So what the problem is, so although the injuries happen, so these days the trend is to go for repair of the ligament. So the ligament is repaired through the surgery. We call it as ACL reconstruction surgery. So where the graft is taken either from the patellar tendon or from the hamstring muscles, and it is replaced at the original location of the ligament. And the new tendon, which is now a ligament, is supposed to work as a stabilizer to play the actual role which the ACL was doing, right? And one of the primary goals why people undergo ACL reconstruction rather than going to the conservative management is because they want to return to sports. So they have the goals to return to sports because of different reasons. Some want to play. Some people have their jobs related to it. They are on scholarships, which comes from the sports. So unfortunately, the problem is this goal is not satisfied 100%. So people with ACL reconstruction, they return to sports, but only 55% return to the competitive sports. The others, they change their sport to the lower level, means if they were playing competitive before, now they will be playing some sort of recreational sport, or their performance is not up to the mark. So the first goal is not met. And secondly, what we see is there is altered movement pattern. So altered movement pattern is, so I'll be talking about this in detail in our next coming slide. So that's why I want you to understand this, what altered movement pattern is. So what it means is if the knee range of motion is full extension and full flexion, it is not achieved following the surgery. There are some impairments, some physical impairments, and some altered degrees of range of motion and the muscle impairments which persist. And it is thought that all of these changes, especially the changes in the movement pattern along with the muscle weakness, it all leads to knee osteoarthritis within 10 years after surgery. So just imagine if someone had someone had the ACL injury at 20 years of age, he's going to end up with knee osteoarthritis when he's in his 30s, and that's not an age to get knee osteoarthritis, isn't it? And the severity is really bad, as you can see here in the X-ray. So we have radiological evidence that knee osteoarthritis is there. So that's why the people with the ACL reconstruction surgery who have knee osteoarthritis developed, they are known as young men with older knees. So because at the 30 years of age, if you have this sort of knee joint, of course, it's an old man's knee, as they say it in the literature. So this is one of the consequences, but very major consequence. And in 2007, so this is, if you will see this graph here, the x-axis is a number of years for the follow-up for people with ACL reconstruction, and this is a percentage. On the y-axis, it is a percentage of the radiographic osteoarthritis. And each dot represents how the ACL reconstruction was done. So either after injury, even if you manage the broken ACL ligament through non-surgical management, even then people are having osteoarthritis at 10 years. See these round dots? Or if you use the autograft, which means taking the graft from the same person's knee, same person's contralateral leg, or just suturing the ACL ligament if it is diagnosed at the right time, or allograft, which means taking a cadaver knee. So it doesn't matter which sort of treatment has person undertaken, all of them you will see are ending up with having knee osteoarthritis. So that's not a good outcome at all. Depending upon, see, how many dollars are spent on the ACL reconstruction surgery, people go for rehabilitation, which is for 6 months, and then they struggle to return to sports. And what happens in 10 years? This is the outcome we're looking here. And the problem is much more bigger when we look at the incidence of other osteoarthritis. So this is the age group here. So people with knee osteoarthritis are they're constituting a huge number here compared to the hip osteoarthritis. So this is what the normal consequence is. Around the 70 to 75 years of age, the x-axis is the number of years in age, and the y-axis is the incidence rate of the osteoarthritis. So already we know there is age-related knee osteoarthritis plus ACL reconstruction surgeries. The people who get osteoarthritis because of that are further added up to this, adding the burden for the overall health system in every country. So this is how you will see a person's X-ray who has undertaken the ACL reconstruction. So the sutures, the nails are here to fix the ACL ligament, the new ligament. And the consequence is people progress over next 10 years from the normal healthy knee to this sort of knee. And we have the data that later on we have more people ending up with the knee replacement. So 35 years, 40 years, ending up as with the knee replacement is again a not favorable outcome. So what are the changes we see? So what happens in those 10 years? So we have a lot of data based on that. So we have the altered movement pattern, and altered knee movement pattern consists of altered knee flexion movements and altered knee kinematics. So when I talk about kinematics, it means angles. So the knee flexion, extension, rotation angles, they are altered. If we will look at a person with knee osteoarthritis, the angles are going to be different than a healthy knee. And then altered knee flexion movements. So the flexion movements represent the loading at the knee joint. Okay. So if there is reduced loading, which also means the muscles are, that may be because the muscles are generating less torque. Torque is the force output generated by the muscles when they're contracting. So movement pattern is altered, and then the muscle strength, quadriceps weakness is known at different time stages. So I'm just talking at the short-term following surgery, which is up to 2 years. And the hamstring and the quadriceps ratio is altered. So there is a normal balance, how stronger hamstrings or the quadriceps should be for a normal muscle pattern, right? So this ratio is altered, and the graft site morbidity persists for a long time. what this means is, so the area from where the graft is taken is seen to be weaker for next few years. It does not recover as it was thought to be. And not just there, so we also have some alterations in the sensory motor system. So the term we are using is arthrogenic muscle inhibition. So we know the ACL was repaired, which means it is a joint surgery, but the problem what we see is in the muscles. So the quadriceps muscles, they are weakened. So arthro means the joints, right? So because of the joints, the problem is in the muscles. So the muscles are inhibited. And also, based on the MRI findings for the central nervous system, the cortical inhibition is also reported. So it is probably the combination of all which leads to the outcomes which we just talked about. So looking at the problem is major. It's at every level in the short term. So I decided to do my PhD to explore even if the full recovery is possible, like what happens after 2 years, because most of the studies which were reporting were up to 2 years or 3 years. Long-term studies were not available at that time, not many at least. So I wanted to explore, do the physical impairments persist in the long term? Like what happens at 10 years, at 15 years? So what I did, so this is the first review I started with. So this is a systematic review done with the meta-analysis, and I explored the movement pattern of knee following ACL reconstruction. So the theory is that altered lower limb mechanics, which I said, altered flexion movements and angles, they can be the risk for development of the post-traumatic osteoarthritis. That people walk in a weird way, that's what is leading to the post-traumatic osteoarthritis. So that's the theory behind, that's how we thought. So I thought that the problem is that injured leg in the same participant, injured leg is having different mechanics than the contralateral, I mean the other uninjured side, and also the biomechanics of the knee during a gait, the walking, are going to be different from the control group as well. And precisely, I was interested in knee flexion angles and movements, so which means just focusing on the sagittal plane and the frontal plane. Though I explored the rotational component as well, but because of some methodological limitations, we didn't publish that much on the knee kinematics in the transverse plane. So I'm going to keep this presentation focused on the frontal and the sagittal plane angles and movements. So what is coming up next is what is flexion and adduction movements. I'm just going to take you guys through it, and I hope this video works. Okay, so what I want you guys to see is, so this is regarding the methods I'm going to use throughout this presentation, and that's what I use for my study. So basically, how we measure the knee flexion movements and angles. So I'll talk about the groundwork a little bit later, but this is about the ground reaction force. So as per Newton's third law, when we touch the ground touches us back, and what we get is the ground reaction force. The vertical one is a more important than the medial lateral and the anterior posterior. So we have the force plates embedded in the gait lab, which I'll show you later on. So this person is walking in the gait lab on the force plates, and force plates measure the ground reaction force. And we normalize it with the weight of the person's body. And these represent X, Y, and Z plane. So if you will look here at this one, the ground reaction force is changing when the person strikes the force plate, okay? And similarly, we are getting the angles. This represents the degrees for hip abduction, flexion, knee abduction, flexion, and ankle, right? So, but for this presentation and for my study, I was more focused on the knee rather than at the hip and the ankle, okay? So, see the numbers changing, and those are the numbers which are recorded, right? So ground reaction force. So ground reaction force passes at some angle or at some distance from the joint, okay? So the moment is the product of the torque generated by the muscles and the perpendicular distance from the perpendicular distance from the joint center, okay? So the peak knee flexion moment, you're gonna come through this term a lot of times. So peak knee flexion moment, it represents the torque generated by the quadriceps. So we have these are the external flexion moments. So what this means is when we are walking, we are moving, the gravity is trying to pull us back, right? So that's the external torque generated by the gravity. And to counteract that force, our muscles generate a considerable force, right? And those are the internal movements. So external knee flexion movement here is equal to the torque generated by the quadriceps, right? So when we are walking, that's what we see the movement pattern as. So positive represents the extension moment, and negative is the flexion moment here, okay? So that was this was in the sagittal plane, front to back, right? And then in the knee, for the knee adduction movement, so this is in the mediolateral plane, okay? So you would have seen the people with bow legs. So how that changes how that is harmful is because of the ground direction, the adduction moment, okay? So this is the ground direction force. So adduction moment is the product of movement arm, how far the ground direction force is being acted on the knee, right? So ground direction force multiplied by this distance is equal to the adduction moment. And during walking, what we see is the pattern of the adduction moment is double humped. There is first peak, which comes when we hit the ground, when your heel strikes at the foot. I'm just talking about one stance phase of the gait, okay? So when your foot lands, you get the first peak here, and then there is foot flat, so the force dampens a little bit, that's why there is a dip. And then during the toe off phase, you push against the ground to take the next step, right? So the second hump is seen. And what we see is there is significant difference in the injured and the uninjured knee. So the injured knee is here and uninjured is here. So the control group is far different than here in this one. So this is one from a participant with knee with ACL injury and reconstruction. So that's what basically is trying to see, the double hump pattern, okay? So I'm going to talk about these adduction movements and the flexion movement. So again, coming back to the review, I wanted to explore to compare the knee kinematics and kinetics during different activities such as walking, running, and stair climbing. And I wanted to see if ACL reconstruction people, they have differences compared to the contralateral limb and the uninjured control group. And if the pattern changes by the time since ACL reconstruction. So what I did was, so I did the data search on the databases such as PubMed, Google Scholar, Web of Science, and others, and I looked for the observational studies done on men and women with ACL reconstruction with any type of graft, and then especially the studies who have included these variables during these activities, peak flexion angles and movements during walking, stairs, and running. So finally, I originally got 1,200 studies. By going through the process of conducting the systematic review based on our inclusion and exclusion criteria, I ended up with 27 studies. And the risk of assessment was done through the Downs and Black criteria, and then I extracted the data, extracted the peak kinematics and kinetics, which means peak angles and the moment. And then the data was plotted through the Raveman Manager, which is a free software. So this is what I'm going to talk through in my next slides. I just want to make you aware that these are the forest plots which Raveman Manager generates. So each line here is a study. Okay, so this study was done at 9 months, having two groups, ACLR reconstruction and control. Means for the angles, standard deviation for the angles, how many participants took part in this study. So for the control group, and the mean differences are calculated by the Raveman Manager. And you will see these lines here. So these are the forest plots. So this one for each study. And if the study, if this dot is on the left side compared to this middle one. This means the differences exist. If this line is touching the middle one, the horizontal one is touching the vertical middle one, there means no differences for each individual study. And then the Riemann plots and concludes the whole thing. Like if this black diamond is away from the middle line, it means there is decreased rotation, okay? So I'm going to take you through the forest plots with the studies I had. So for the flexion and adduction angles, so what I did was I grouped all the studies based on the activity they were. For example, these are all the forest plots for walking when the comparison was made for the control group, then with the controlator group for walking, and then for stair ascent for the control group, and then during descent and running. So what we see here is during walking, there are no differences between injured and uninjured leg compared to the control group, okay? But the differences exist in a person when we compare his movement pattern on the injured side and during the uninjured side, because the square is on the left side, right? So flexion angles are reduced. That's what it means. And so on. During stair descent, we had fewer studies, but what we see is the differences persist, okay? So for the adduction angle, we didn't see any differences here. And then for the movement, what we see is for the flexion movements, what we see here, the differences persist for walking when we make the comparison to the control group, to the contralateral side, for the stair ascent, for the control group, and the contralateral sides, right? And similarly for the adduction moments, there are no differences during walking, but some differences persist during the comparison with the contralateral limb. So overall, though the angles are similar, which we saw in the previous forest plots, so the differences, there are not much differences in the angles, but the differences persist for the moment, especially the lower flexion movement, which we saw represents a quadriceps function, which could be because of the different reasons. It could be due to the pain, reflex inhibition, asymmetry between the limbs, and different neurophysiological mechanisms, which we know play a bigger role, as we discussed in the beginning. So, and the lower adduction movement, which looked at that it was moving from the lower to the higher level. So this was based on the forest plots we saw. So what we concluded that it seems like the angles appear to be normal at 6 years, but the movements, the flexion and adduction movements, are lower compared to the controls. So this was our concern. So it means the knee function is not fully restored, and all the included studies were at the mean time at 4 years after ACL reconstruction. So probably these differences in the movement pattern, which means altered movements, because those represent the loading at the knee joint, they may be the risk factor for early degeneration for the joint. So this study was published in 2016 in Sports Medicine Journal. So it means the story is not over for people with ACL reconstruction. We need to keep on rehabbing these people. So based on what we got from the previous study, we designed a cross-sectional study from the systematic review, because we saw the flexion movements and the adduction movements are different. So we designed this study, but the activity we chose was not walking, it was the stairs. So that was what we saw during stair ascent and descent, that differences persist, because it might be because this is a more challenging activity than walking. So that's why I chose stair ascent and descent activity for the participants. So what I did was I compared the knee angles and movements in people with ACL reconstruction and compared with the contralateral leg and the control group during stair ascent and descent. So I hypothesized that there will be lower flexion movements compared to control group during stair ascent and descent, and contralateral limb in people with ACL will exhibit higher flexion movements and angles compared to ACLR knee and to the control group. So this was a cross-sectional study I recruited from the community in New Zealand. So all men and women between this age group from 2 to 10 years with any type of graft were included. People with the revision surgeries, re-injuries were excluded. And we recruited an age-matched control group. So this is a setup I want you to see. So these are the force plates, and we had the 12 camera set up at different angles and positions to record the angles. So the cameras are going to record the angles, and the force plates are going to record the ground direction force. And the ground direction force is the one which gives us the moments. So what we do is we put the markers. So we put the markers on people. So there are the reasons why we choose these landmarks. And then we do the static and the dynamic trial. So the cameras record the angles and the position of these markers. So this is a setup we use. So the ground direction to calculate the ground direction force. The force plate is embedded here, and the person was asked to move to descend and ascend the stairs. Okay, so this is a setup. So we ask this person to stay a step back and then move and walk with one leg first and then with the other leg. Okay, so while this is happening, these angles, these cameras, which is everywhere in the lab, infrared cameras, they are recording the position of these markers. Okay, so five trials were done for the injured and uninjured leg. 5 trials with each leg, and total 10 with the uninjured and the injured leg during stair ascent and descent. Repeated measures ANOVA was done to see if the differences are there between ACLR and the control limb. So overall, we had 25 participants in the ACL group and 24 in the control. So yeah, the people with ACLR were a little heavier than the other group. So what we see here is the results. So we see there are the differences, ACL reconstruction leg. So these are the angles, the mean differences, okay? And this is a standard deviation. So we saw there are the significant differences between the ACLR leg compared to the control group and also compared to the control side too. So we randomized dominant and non-dominant sides in people with for the control group. And ACLR1 is the injured side, okay? So injured side had differences in the knee angles compared to the control group. And flexion extension excursion means total knee flexion minus total knee extension during activity is excursion angle, the total range of motion available. So huge differences were seen. Again, injured side with the control side 1. And these are the movements. So between the ACLR and the control side. So the flexion movement on the ACLR side was lower than the contralateral limb and also to the control side 1. And extension movement. So the participants seemed to have higher extension movement, which means using the posterior muscles on the leg. So they were using more muscles on the posterior side, which is not normal. So there were no differences seen during stair descent, as you can see here. So lower flexion angles during stair ascent compared to the control group and and the reduced knee excursion was seen. So small alterations in the angles might lead to the distribution of the load on the articular cartilage. Okay. So although the changes in the angle is small, but that may be significant because you are walking or doing those activities throughout the day for a long time. So altered movements represents that some sort of impairments persist, physical impairments persist. The muscles are not working the way they should be, okay? So lower joint loading, it might be due to the hesitancy or the quadriceps muscles are not activating as they should be, or participants are reluctant to weight wear on the injured side, or it may be a compensatory behavior of the participants. So because the participants were from 2 to 10 years after surgery, so it suggests us there is incomplete recovery in these people. So gait pattern is altered. This is the clinical implication that gait pattern is altered and it persists for a long time and it may be leading to the knee osteoarthritis. So I'm just rushing a little bit because I want to add all of this. So we also recorded the patient reported outcomes. So this is the knee osteoarthritis, knee outcome osteoarthritis scale. So what we see here is participants with ACLR having more pain and knee symptoms compared to the control group. So higher the scores are, it means the better is the outcome. If the lower the scores, that means bad outcome. So more pain and knee symptoms, and also poor function in sports and recreation and quality of life compared to the age and gender matched control group. And also, I recorded the muscle strength using the isokinetic dynamometer, and what we see here is that ACL injured side. So this is injured side, this is uninjured. Then look for the control group side 1 and side 2. And this is based on the repeated measures ANOVA. So the quadriceps concentric strength is weaker compared to control side 1. And also the differences, side-to-side differences persist for quadriceps eccentric and hams eccentric in the injured and the uninjured side. And then the jump distance. So participants were asked to perform 3 trials of horizontal hop. Participants were asked to jump as far as they can. And what we see is participants jump for shorter distance compared to uninjured side and also compared to the other sides. The knee laxity, I measured this with the KT arthrometer, KT 1000 arthrometer. So this knee, the injured knee, ACL reconstructed knee seems to be so much lax. So this is in the millimeters, how much tibia can be pulled forward with the arthrometer. So this is huge compared to the other sides. So that's not all of it. So I also interviewed 10 people who participated in this bigger study. So people did the movement patterns in the lab, they did the strength testing, they did the functional assessment. In addition to that, I wanted to explore participants' life, their experiences in relation to physical activity, sports, occupation, and health-related quality of life. So 10 people were interviewed face-to-face. So they did the questionnaires, patient-reported outcomes, and also participated in the interview questions. And what I see is the results were a little surprising. So the level of physical activity was reduced significantly based on the non-parametric tests we did. And also quality of life is poor. So again, this is the KOO score, knee osteoarthritis outcome scale. Higher the scores, the better is the outcome. Poor the scores is bad. Quality of life is 53 out of 100, which is similar to someone who is 60 years of age. So this is not what we want, right? So 3 themes were identified. The fear of re-injury was present even at 6 years. So the mean time after surgery was 6 years. Fear of injury still persists, which is bad. And they had the ongoing health-related problems, and they indicated that they need health professionals' advice. And the fear of injury is known to have huge consequences. So these are the different reasons why they experience this pain, and these are the consequences which they get from the fear of injury. It leads to low confidence during sports, hesitation in sports, and some people still wear brace while playing. So these might be the factors leading to not to return to sports, which we discussed in the beginning, right? So it's a lot of psychological component as well. That's what I want to tell you, in addition to the muscle strength. So previously it was thought that fear of injury persists. We knew that it persists after 2 years, but now it persists up to 10 years. So that's why patients have fluctuating level of confidence, and also for us, for physios, it's good to know that patients still experience the knee-related symptoms, okay? So that's what we need to treat in these people. So people are concerned about the risk of re-injury and osteoarthritis, and it persists for the long term. If we think ACL reconstruction was done, person has done the rehab, the story is not over. It still carries on, and it persists, and it has a lot of consequences for long term. So this study was published last year. So this is the overall picture. I study the people from 2 to 20 years. So though today I'm presenting the data up to 10 years only. So what I can say strongly is the differences in movement pattern persist. There is poor hamstring and quadriceps strength. Fear of re-injury persist. Sensory motor changes as reported by other studies. They are present as well, which means because the ACL is taken out, less sensory information goes from the new ligaments. Okay? So when looking at the patients in the long term, we need to have the holistic approach for these patients, which means we do not just need to perform the quadriceps strengthening or the hamstring strengthening or the core stability. We need something more as well, maybe considering the psychological factors. So that was what I did in the past, and now what is the next direction I'm taking? So I'm exploring that how the fear of injury influences the injury outcomes. Okay, so I'm interested how basically the fear of injury influences a movement pattern, and also I'm involved as I'm trying to develop the video games based interventions for patients with knee osteoarthritis. That's what I'm doing at the moment. So this is EMG based study using the EMG and the video game based interventions for people with knee osteoarthritis. So now I'm a member of, I'm a faculty member in the University of Virginia, and this is the setup we have. So this is an isokinetic machine used for muscle testing. The gait lab, we have this treadmill embedded. So we have the force players embedded under here. And rest of the lab for doing the hop tests and stuff. So this is my present workplace, and we get a lot of patients in the database. So we are testing healthy and the ACL people, and we are doing the muscle strength testing, hop testing, balance error scoring system. So we are getting a lot of data of the participants, and we hope to publish more in the coming years.
There's one question from Sagarika Sharma. How to go ahead with a treatment protocol based upon degree of injury, especially for athletic population?
So it really depends what is the extent of injury, right? What is the extent? I mean, is it a full tear or partial tear, right? And secondly, more than that, what is the goal of participant? Does he want to return to sports? Like why? What is the goal for treatment? One is we want a stable knee, right? Or if the person wants to return to sports, the people try to take shortcut and go through the surgical approach rather than the conservative approach. So the first we have to choose is whether we want to go through the conservative management or the surgical, right? So if this is surgical, what are the goals? Do they want to return back to sports, or what is the goal for that, right? Or if it is just stable knee, what one can do is one can try the first approach using the conservative rehab, which means strengthening the knee. But if there are the giving way episodes, if the knee gives way, if the knee buckles while walking, then probably this is an indication that patient needs more than that and should be the surgical approach which patient should be taking.
There's one more question. So, what exercise can be done to increase the flexion and adduction angles after ACL reconstruction surgery? So, you have told in your study, na, so there is decreased adduction and there is decreased flexion torques, so which has as compared to control. So, what exercise or what regime can be followed to do that?
So for the flexion movements, um, because we know that flexion movements is are equal to the torques generated by the quadriceps. So what we do is our main focus is on strengthening the quadriceps as much as we can, right? So performing the squats and other neuromuscular electrical stimulation. The problem is we know that strengthening works, but because of the sensory motor pattern, there is quadriceps inhibition, and which we are so far not able to recover. So a lot of studies are being done. I mean, we can improve the quadriceps strength a lot, but by doing the standard exercises such as lunges and the squats, the single leg squats, perturbation training, but there are some impairments which seems like they persist, and a lot of research is being done, like how we can improve more. And this includes doing the neuromuscular electrical stimulation as well. And for the adduction movements, if we want, because adduction movements represent the stability in the mediolateral plane, in the frontal plane, right? So we are not clear how we can normalize the adduction movements in this plane. So studies are being done basically to explore what contributes to the normalized adduction movements. So we are working, the world is working on that. So, but if we see the knee as one unit, it seems like strengthening and restoring the muscle symmetry would help to normalize the adduction movements as well, and angles, of course.
What are the incidences of osteoarthritis after hamstring graft for ACL reconstruction?
Yeah, this is an interesting question. So what we know so far is that there is no gold standard for the type of graft. But what we know is some studies have indicated that incidence of osteoarthritis is more if person has gone for patellar tendon graft compared to the hamstrings. And there are more problems related with the quadriceps than with hamstring graft. So it seems like hamstring is a better approach for if someone has a ACL reconstruction. So he or she will probably get less osteoarthritis compared to the other who has gone for the patellar tendon graft. So incidence is less for hamstring compared to the quadriceps one.
There is one more question. Does genu valgum or varum affect the patient after ACL injury?
Um, yes, it does. Both will affect because both will change the ground reaction force, right? But the question is if the valgum or varum was present before surgery or after surgery. If it is developing after surgery, then it is bad. It's real bad. It's bad in both cases. But having the genu varum, which means bow legs, right? That is a pattern which is seen in people with knee osteoarthritis, which means the medial compartment of the knee will be experiencing more ground reaction force than the lateral side. So that's the worst thing one can have in the knees, especially if someone is young and is having ACL injury. So that means it might mean that a person is progressing towards knee osteoarthritis because it is experiencing more forces than it is supposed to be.
Okay. Which muscles need to be strengthened more, whether quadriceps or hamstring after ACL injury?
Both. The reason being, hamstring muscle group, that's a agonist. That's the agonist of the ACL, the new ACL or the previous one. So the hamstring muscle would be preventing the hyperextension, which can be caused if the quadriceps are working more, right? So we say the hamstring is a friend of ACL because of the forces or the torque generated by the hamstring. It can keep on pulling the tibia behind. So that's how it can prevent re-injury. So that's why the aim is we need to keep a balance between quadriceps and hamstrings. So that's why we know there is altered ratio for the hamstring and the quadriceps muscles. And if we are just focusing on the quadriceps, the chances are it can generate the anteriorly directed force. That's what tears the ACL in the first place. So that's why strengthening hamstrings, doing the single-legged bridges or the other Nordic curls, the Russian hamstring exercises. So those are important as well, in addition to performing strengthening for the quadriceps.